Welcome to This Week in Radiology. This week we're covering 8 notable papers spanning abdominal and pelvic oncologic imaging, advancements in breast and women's health imaging, and interventional oncology for hepatocellular carcinoma. Let's dive in. We begin in the abdomen, where early detection and precise imaging protocols are critical to shifting the prognosis of highly lethal malignancies. In a comprehensive review, researchers outline the clinical landscape of early pancreatic cancer, defined as high-grade dysplasia precursor lesions, and invasive carcinomas measuring 2 centimeters or smaller that remain confined to the pancreas. The authors emphasize that while major modifiable risk factors like smoking, obesity, diabetes, and alcohol consumption, along with genetic syndromes in up to 10% of cases, should prompt vigilance, the key to survival is identifying these lesions early. Precancerous lesions such as pancreatic intraepithelial neoplasia and intraductal papillary mucinous neoplasms are highlighted as highly important due to their potential to progress to pancreatic ductal adenocarcinoma. Radiologists must look beyond direct findings, like small solid masses or enhancing mural nodules within cysts, to recognize subtle indirect features. These indirect signs, which include localized changes in the pancreatic parenchyma and the ductal system, can actually precede a visible tumor by 1 to 5 years, providing a crucial window for intervention. To capture these subtle changes, optimizing our imaging protocols is paramount. A prospective study in the European Journal of Radiology evaluated whether pancreatic computed tomography image quality benefits from using an individualized rather than a fixed post-triggered delay for contrast timing. Comparing 50 patients scanned with an individualized delay to 50 patients scanned with a fixed 20-second delay, the researchers found that the individualized approach significantly boosted objective image quality. Mean attenuation in the pancreatic head reached 126 Hounsfield units with the individualized protocol, compared to just 86 Hounsfield units with the fixed delay. Similarly, in the pancreatic body, attenuation rose to 125 Hounsfield units compared to 93 Hounsfield units. Subjectively, 84% of the individualized scans were rated as excellent or good, compared to only 30% in the fixed cohort, with observers noting far better pancreatic demarcation and duct visibility. Crucially, these improvements were achieved without altering radiation exposure or contrast volume, even though the individualized delays ranged widely from 5 to 37 seconds. Moving deeper into the pelvis, restaging rectal cancer after total neoadjuvant therapy represents another area where imaging is actively redefining patient management. A review in the Korean Journal of Radiology highlights how total neoadjuvant therapy has expanded opportunities for non-operative watch-and-wait approaches, shifting the role of restaging magnetic resonance imaging. Rather than relying on traditional tumor regression grading systems, which correlate poorly with final pathologic findings, contemporary practice integrates magnetic resonance imaging with flexible endoscopy. The identification of a clinical complete response now heavily leverages diffusion-weighted imaging to improve sensitivity for residual disease and specificity for confirming complete response, allowing for a safer selection of candidates for organ preservation. Furthermore, there is growing acceptance that patients with small foci of residual tumor, representing a near-complete response, can be safely managed with short-interval surveillance, further expanding the cohort of patients who can avoid radical surgery. However, as we expand our pelvic staging and surveillance capabilities, we must also navigate the diagnostic pitfalls of highly sensitive molecular imaging. A review in Radiographics addresses the challenges of interpreting prostate-specific membrane antigen, or PSMA, PET-CT, in prostate cancer. Because PSMA expression is not exclusive to prostate cancer and occurs in normal physiologic tissues, as well as a variety of benign and malignant conditions, it frequently produces mimics of metastatic disease. To prevent clinical misinterpretation, the authors advocate for a structured risk assessment approach. This framework requires radiologists to integrate uptake intensity and precise anatomical location, with corresponding anatomical imaging findings on computed tomography and the broader clinical context, utilizing standardized scoring systems to categorize suspected lesions. Next, we turn to breast and women's health, where standardized protocols and rigorous quality audits are driving improvements in diagnostic performance. In the Journal of the American College of Radiology, researchers published a large-scale observational study comparing supplemental screening outcomes for automated breast ultrasound versus handheld ultrasound in over 25,000 exams of women with dense breasts. Analyzing data from 27 facilities within 3 breast cancer surveillance consortium registries, the study compared over 21,000 handheld exams to over 4,000 automated exams. The results demonstrated that automated breast ultrasound was associated with a significantly lower abnormal interpretation rate of 14.9%, compared to 19.2% for handheld ultrasound. It also drastically reduced short-interval follow-up recommendations to just 3%, compared to nearly 15% with handheld ultrasound, and yielded a lower false positive initial assessment rate. Crucially, there were no significant differences in cancer detection rates, biopsy recommendations, or positive predictive values between the two modalities, indicating that automated breast ultrasound is a highly effective, reproducible alternative that reduces patient anxiety and unnecessary follow-ups. This emphasis on quality control and standardized metrics is a core theme of the upcoming American College of Radiology (BI-RADS) version 2025 manual. A review in the Korean Journal of Radiology details 3 major updates to the auditing and outcomes monitoring chapter. First, the manual now recommends routine auditing of BI-RADS Category 3 assessments to ensure this classification is strictly applied to findings with a 2% or lower likelihood of malignancy, preventing its overuse. Second, it introduces a standardized framework for auditing preoperative staging breast magnetic resonance imaging, incorporating both examination level and finding level metrics. Third, the manual encourages the prospective assignment of the initial method of detection to directly link patient outcomes to screening versus clinical presentation, establishing a foundation for global benchmarking. At the same time, standardization remains a pressing need in pelvic floor imaging, where dysfunction is frequently underdiagnosed. To address this, the European Society of Urogenital Radiology Pelvic Floor Working Group published new clinical practice recommendations in European radiology. Because pelvic floor dysfunction frequently involves multiple compartments, the guidelines emphasize that magnetic resonance imaging provides an invaluable, comprehensive structural and functional assessment of all pelvic compartments. Meanwhile, fluoroscopic defecography remains the mainstay for evaluating defecatory disorders, and pelvic floor ultrasound is increasingly utilized to triage dysfunction and assess anal sphincter integrity. By implementing these standardized protocols, key measurements, and a structured compartment-based interpretation strategy, radiologists can ensure consistent and clinically actionable assessments. Finally, we look at interventional oncology for elderly patients with hepatocellular carcinoma, a population where balancing treatment efficacy and procedural safety is exceptionally challenging. A propensity score match study in the Korean Journal of Radiology compared transarterial radioembolization, or TARE, with transarterial chemoembolization, or TACE, in 319 treatment-naive patients aged 75 or older. After matching 55 patient pairs to balance baseline characteristics, the researchers found that TARE was associated with a significantly longer time to local tumor progression, with a hazard ratio of 0.26. The median time to local tumor progression was not reached in the TARE group, compared to 18.5 months in the TACE group, and the complete response rate was marginally higher for TARE, at 54.5% versus 34.5%. While overall survival and time to progression did not differ significantly, TARE demonstrated a vastly superior safety profile. Mild to moderate abdominal pain was much less frequent at 5.5%, compared to nearly 22% for TACE. Furthermore, severe adverse events were dramatically lower in the TARE group at 3.6%, compared to nearly 42% in the TACE group, and the median hospital stay was significantly shorter at 4 days versus 6 days. These findings suggest that TARE should be preferentially considered over TACE for elderly patients with larger tumors or reduced physiological reserves. If you only have time for one paper this week, make it the comparative study on supplemental breast cancer screening in the Journal of the American College of Radiology. This paper provides robust, large-scale clinical evidence that automated breast ultrasound can significantly lower false positive rates and short-interval follow-up recommendations compared to handheld ultrasound, offering a highly practical way to optimize screening workflows and reduce patient anxiety in dense breast populations. Here are the key takeaways from this week in radiology. First, implementing individualized post-trigger delays in pancreatic computed tomography protocols significantly improves parenchymal enhancement and pancreatic duct visualization compared to fixed delays, without increasing radiation dose or contrast volume. Second, automated breast ultrasound is a highly effective alternative to handheld ultrasound for supplemental screening in dense breasts, offering comparable cancer detection rates while significantly reducing false positive rates and short-interval follow-up recommendations. Third, transarterial radioembolization offers superior local tumor control and a vastly safer adverse event profile compared to transarterial chemoembolization in elderly patients aged 75 and older with hepatocellular carcinoma, making it a preferred choice for those with reduced physiological reserves. Fourth, when restaging rectal cancer after total neoadjuvant therapy, magnetic resonance imaging interpretation is shifting toward a watch-and-wait management paradigm, utilizing diffusion-weighted imaging to confidently confirm clinical complete response and expand eligibility for organ preservation. And fifth, the upcoming BI-RADS version 2025 manual introduces vital auditing updates, including routine audits of Category 3 assessments and a new framework for preoperative breast magnetic resonance imaging, aiming to standardize performance metrics globally. That's your roundup for This Week in Radiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.